So hi, everyone. I'm Dr. Nicole Tartaglia, and we are going to speak today about autism and X and Y variations and how they overlap. I'm a developmental pediatrician at Children's Hospital Colorado, and am happy to introduce one of my colleagues, Dr. Rebecca Wilson, who has worked with our clinic for over 15 years now, doing evaluations and recommendations for autism and social development in X and Y variations. And also Caitlin Middleton, who is not part of this slide presentation, but will be joining us for the Q&A, who's another great psychologist in our Extraordinary Kids Clinic.
And hi, everyone. I want to also say hi. I'm a psychologist, been really grateful to work with Dr. Tartaglia for all these years, and particularly grateful to work in our Extraordinary Kids Clinic.
So our plan today is going to be to talk a little bit about just autism by itself. What is autism? We want to remind everyone we're going to try and cover both kids and adults, or the material covers both kids and adults. We are both, we work in pediatrics, we work in a children's hospital, but a lot of our patients are late adolescents, young adults, even, middle-aged adults sometimes. And so a lot of this content really covers across the lifespan. And please feel free to ask questions at the end about differences after we go through this overview between kids and adults and things that may be relevant to adults as well. We're going to talk a little bit about the autism research that's happened in X and Y variations. We can't cover it all, but I'm going to summarize a lot of the work that we've done and a few from others. We're going to talk about evaluation and approaches to treatment briefly, and then, have a big period of time for questions as well. So Dr. Wilson is going to start with this topic, and then I will jump in after.
So let's just talk briefly about what is autism. It is 4 times more common in boys than girls, and 30 to 40% of all diagnoses of autism have a genetic cause. And this is a number that keeps growing, and it's grown over my career. And that's part of the reason why we want to talk about this, because we know that autism is a little higher in our conditions than it is in the general population. And this is the other number that you may be seeing. We now know that the prevalence of autism is as high as 1 in 36 in 8-year-olds. And this is a new number that's been published by the CDC. So let's just talk a little bit about formally what is autism. An important point here, and I won't go into all the detail of on this slide, but the important point here is that autism as a diagnosis reflects deficits. There needs to be a disability. It's not just a difference, it's deficits. And we really, when we evaluate for autism, there's 2 areas that we are considering. The first is persistent deficits in social communication and interaction. This can relate to conversation. This can relate to back and forth play. This can really relate to the overall ability to develop sustained and meaningful reciprocal relationships. And then the second big area is restricted and repetitive behaviors. You have to have 2 of 4 of these. And some of these pictures represent a little bit of what you might see in autism, with insistence on sameness, some rigidity, some things like that. Also, when we make a diagnosis of autism, we specify the current level of severity. This is not predictive, but it just speaks to the level of support a person needs at the time that the diagnosis is made. So we all know that a spectrum really is represented by this idea of something's worse on one end and better on the other, or more severe at one end, less severe at the other. And this is the way we used to think about the term spectrum, with individuals that were less autistic at one end of the spectrum and people that were more autistic at the other end of the spectrum. But now we recognize it's really far more complex than that each area of concern may have its own spectrum. And So long story short, if you've met one person with autism, you've met one person with autism. Everybody's very unique with lots of differences in each area. And then the new and really, I think, important point to make is this idea of neurodiversity, that we all have differences in the way we approach things. And in autism, we specifically think about there are individuals that really could be described as having differences, not deficits. And our work is to determine if there is a deficit and if somebody needs support. And so if you really think about it, we all have all of these differences. All of us have motor skill differences, perception differences, executive functioning, organizational differences, sensory differences, and language differences.
So now we're going to transition to talking about autism research a little bit in X and Y variations. But before we do that, I want to start by really talking about the problems with autism research in X and Y variations, because there's a lot of limitations in our understanding. First of all, a lot of the studies that have really looked at autism in X and Y variations have small sample sizes, 20 patients, 30 patients, even 70 patients. And that often, is not really representative of a really strong sample size to be able to tell what's happening in the bigger population of all individuals with X and Y variations. We talk a lot about ascertainment bias in research, and the idea of ascertainment, or where you're ascertaining, where you're getting your patients from, is biased in research, right? We're not, in most of these studies, taking every single individual who has X and Y variations because, number one, many times they're not even diagnosed. Number two, maybe they're not participating in research, right? And the individuals who are in our research and who are diagnosed to be participating may be more affected than an unbiased sample. There was some reason those individuals were identified, and some reason someone did genetic testing. Now, sometimes it is a prenatal diagnosis. We'll talk a little bit more about that. But other times that there's a diagnosis, especially if they were diagnosed in childhood, in early childhood, there was some reason why someone was sending genetic testing, a developmental difference, a motor skills difference, or even testing after a diagnosis of autism has been made, which also is another way that sometimes our X and Y variations are diagnosed. The other thing is, even if you have a whole, if everyone in the world was identified, there are certain people that are still coming to clinic. There are certain people who are at the sites and seeking input from the places that we recruit from clinics, from support groups, from Facebook pages, all those different things. The people who are going to those places are more likely to be needing support, right? So you're kind of washing out some of those individuals who have fewer challenges. Not all, we love everyone being involved in support groups and Facebook groups, but generally those who are more likely to be involved are likely those who are more likely challenged, and by different aspects of that spectrum that we see in the X and Y variation. The other challenge is that very few studies evaluate the role of family history or other genetic and environmental risks for autism. So as Dr. Wilson was saying, 40% of the time now in autism, we can identify a genetic cause. And sometimes in our X and Y variations, there's another genetic cause. And even without a clear genetic cause that you can identify, we know from research, there's very high rates of heritability in autism and risks for, family members, even when we don't know what the genetic difference is. And then there's also some other environmental risks. So, to really get a good idea of how much of this is specifically related to the X and Y variation needs a very big sample size with all of those data controlled for. And, and it doesn't minimize the research that's been done, but it just tells us it's incomplete. It doesn't tell us the whole story. You'll see us a lot of times talk about the differences in a prenatal versus a postnatally diagnosed group. And so, and the strength of a prenatally diagnosed group is that there's obviously less ascertainment bias. We're not identifying that individual related to the presentation of delays. They're just diagnosed prenatally. It doesn't mean that that individual with a prenatal diagnosis can't fall anywhere on our, spectrum of strengths and weaknesses across all the different domains of the X and Y variations, but they have the potential to be anywhere, right? When you have a prenatal diagnosis, as opposed to, oh, we're testing you because you have a delay. And so that's why we're identifying the X and Y variation. So there's definitely less ascertainment bias in a prenatal diagnosis group, but it's not absent, because those who are prenatally diagnosed and seeking input or seeking support or participating in research are still a little bit more likely to be, having challenges. But it does give you a difference in terms of making sure that we're talking about a prenatally diagnosed group or a postnatally diagnosed group when we're thinking about prevalence rates for sure. Okay, so what do we know about rates of autism in the X and Y variations? Well, there's a lot of studies, but there's some of the bigger studies. Bruning et al., which is a group from the Netherlands, evaluated a big group of individuals with XXY using an autism diagnostic interview and found that 27% of males with XXY in their group met criteria for autism. But again, this was, a sample that was highly ascertained from a clinic population or recruited from affected population. Sophie Van Rijn's group did another study in adults with XXY using a questionnaire called the Autism Spectrum Quotient. And what they found was results showed that there was increased distress during social interactions, and total scores on the ASQ were higher than a control group. And 48% of that sample was above the cutoff for Asperger's syndrome. Asperger's syndrome was a previous term that is no longer an accepted diagnosis when you're making a clinical diagnosis of autism, but it meant that it was a kind of higher functioning form of autism compared to more traditional autism, and it was a lot of social communication challenges. It's no longer a diagnosis since 2015, when the new DSM or the new Diagnostic Manual for Autism came out. In 2006, there was a paper about XYY, 26 patients. So again, remember, really small sample sizes, 19% met criteria for autism. And then we did a study, our group, and then Dr. Judy Ross's group, looking at and doing direct evaluation for autism in the three groups of males with X and Y variations, including XXY, XYY, and then XXYY. And we did a full diagnostic evaluation and looked at all sorts of different things, but really wanted to come up with whether or not they met criteria. And if you took the whole group, what we see here is this is 2 out of 20 individuals in the sample had, and 10% met criteria for autism. In our XYY group, there were 57 individuals, 38% met criteria. And then in our XXYY group, 21 individuals and 52% met criteria. So these are rates that, again, are important. It's important to describe the features, and it's important to document that it's there. But again, while sample sizes are small and together they all add up to a higher sample size, but when you break them down individually, they're smaller. And it was also a recruited group, right? We want you to come for a study on social development. Well, who's going to, be most interested in those studies are those individuals who maybe are having social developmental differences, right? I do want to we talked a little bit before about comparing this idea of a prenatal versus a postnatal diagnosis. And that's really important for all of those families out there who have a child with a prenatal diagnosis, because those rates that I just showed you sound very scary, right? They sound like, oh my gosh, that's a really high rate. And, it does highlight the risk, but we want to also talk about the differences in prenatal versus postnatal diagnosis, because for those individuals with a prenatal diagnosis, the risks are lower. And so we actually did show this in another study of trisomy X. So now getting into the trisomy X group, that when we looked at a population of 74 individuals with trisomy X, this was led by Dr. Crispin Wigby, who's a geneticist now at the Mind Institute in Sacramento. And basically 8 of that 74 had a diagnosis of autism, so about 10% or 11%. But when we divided it between the prenatal and postnatal groups, 6 of those were diagnosed postnatally, and only 2 of those of the 44 with a prenatal diagnosis were diagnosed with autism. So 5% of the population. So, that is a significant difference if your risk is 4.5 versus 20%. And I think that's really important in terms of thinking about the prenatal versus postnatal populations. It's also, highlights that while it's lower in the prenatal group, it doesn't mean it's absent. There's still a need for screening and evaluation as well. So not all of the differences are definitely accounted for by ascertainment bias. We're doing a study now that many of you know about that's called the Extraordinary Baby Study, where we are taking big groups of individuals identified at birth and following them from birth on, so that there's less bias about who's participating in research, how, why they're interested in research, because there may be challenges. And we're going to learn a lot more about prevalence rates of autism in this group as they age, and we follow them through their lifespan. And then also we're going to learn about predictors. Are there some early predictors of autism as well? Okay, so talking about, what's the overlap? That's the point of this talk, right? What's the overlap of the features of autism and the risks and the X and Y variations? So over here, I have all sorts of different aspects and things that we see in kids with autism, starting with some of these pieces that Dr. Wilson talked about: speech delays, higher level language or complex language understanding, and difficulties with social communication, difficulties with social relationships and friendships and reciprocity, sensory sensitivities, changes in routine, lack of social motivation, or wanting to engage with others. And then some of these other pieces here, rituals, routines, motor behaviors, rocking, spinning, flapping, strong restricted interests or unusual interests, decreased eye contact, flat or atypical speech, and then some of their strengths: strong nonverbal skills and visual spatial skills, and then increased risks. There's high rates of comorbidities of anxiety, of ADHD, of motor planning or motor challenges in kids with autism as well. So now look over here at our X and Y variation risks. We know these are all risks. They don't happen in everyone, but risks in X and Y variations, and how many times there are similar risks, right? We see a lot of risks for a lot of these challenges in kids with X and Y variations. Whether or not that risk is meeting the criteria for autism is where your evaluation comes in. I mean, we really need to know, if these challenges are present, how much impairment are they causing, and are there enough of the criteria together to meet a diagnostic criteria for autism? The other piece is that we have some differences, right? Where are the places where there aren't overlap? And there's a lot of really important pieces here. Generally our kids with X and Y variations, it's different in everyone, don't have really strong or unusual interests in routine. We don't see a lot of atypical motor behaviors, rocking, spinning, flapping. We do see sometimes restricted interests or strong interests, but not usually in the same atypical way that we often see in kids with typical autism. Decreased eye contact or really strong avoidance of eye contact is often also not part of our picture. And then, oftentimes, while there are social differences in the X and Y variations, many times it's more social emotional immaturity. They have typical social development, but it's just a little bit lower than their developmental age. And so that's also something that is unique here and makes us look at social skills for sure. And then the evaluation's job is to help sort out, is this immaturity, or is this something that's a more a deficit or a challenge in social development? One of the really important pieces that I want to spend a little bit of time on too is talking about social motivation. Many times when we make a diagnosis or start to talk about the question of autism in kids with variations, we hear families say, well, people tell me he can't have autism because he makes eye contact and he wants to have friends. And so isn't it that kids with autism just don't want to have friends or they don't care about social interactions? And that's kind of a big myth about autism in general. So that, that there's not social motivation. But one of the really important things that we see in our X and Y variations is that our social motivation in these guys and girls is often preserved. They want to have friends and develop reciprocal friendships and social relationships. They just have a challenge with how to navigate that, especially as they get older, and that navigation and the complexity of social skills gets a lot harder. And so we did do a study where we did a questionnaire that evaluated social skills in a group of kids with X and Y, with the males with X and Y variation. We ask questions about social awareness. How do you understand what's going on in your social world? Do you know the social rules in terms of social cognition? What is your communication like in terms of just, back and forth, reciprocity and things? Do they have social motivation? Do they want to engage with others? And then autistic mannerisms such as repetitive behaviors and other things. And what we found was that there were differences in many of these other areas compared to our normative sample or our typical population. But social motivation was not different compared to kids with X and Y, without X and Y variations. So there was a preservation of social motivation. Our kids want to, and our adults want to have social interactions. They just have challenges with doing it. And how to do it. And that's good in a lot of ways, because if you have social motivation, you're also more motivated to make changes, right? If we're implementing an intervention, then it is there's more kind of buy-in into and more ability to help with those social pieces. This is a little bit of a simplified picture of a big model, but another big difference we see is that oftentimes we end up diagnosing our individuals with X and Y variations with autism later than we do the general populations. And so what we see is that there is kind of a delay and then a pattern where they're not keeping track with the pace of peers. So, as we grow up, there's this increase in the expectation of social complexity, right? Or increase in the complexity of social expectations. So, down here, when you're younger in age, there's play, there's, it's not very complicated in terms of how you interact when you're really young and just playing and running around with each other. But as you get older into the teenage years and even beyond that, right, there's a lot more complexity in understanding the rules of social interactions, of, reading between the lines, of knowing how to kind of banter back with your peers. And as that gets more complex, oftentimes our kids with and teens with X and Y variations kind of can't keep up. So they don't keep up with the pace of peers, and they don't understand that complexity, even though they were really good at the stuff when they were younger. And so that's where oftentimes when that deficit or that difference is causing impairment, where we'll often start to also make a later diagnosis of ASD. Okay, so then when we do make a diagnosis, what is it? Is it the X and Y variation, or is it autism? And the answer is really that it's both. It's autism caused by the X and Y variation. So the way that we picture it in our clinic is the X and Y variation is on top. That difference in the genetics leads to differences in brain development, and that puts all individuals with X and Y variations at risk for an autism spectrum disorder. If they meet those criteria following an evaluation, then the diagnosis of autism is applied. And so why make the diagnosis if it's caused by an X and Y variation? And that's what we know. Many of you may have already experienced that when you tell someone, I have trisomy X or I have XXYY, no one really knows what that means. And so they don't know how to support that often, right? So we really feel that it's most important to make a diagnosis so people understand autism. They've heard it. There's programs for it. There's treatments for it. There's school settings for it. It doesn't always fit perfectly. for everyone because of this difference in the spectrum, but it is important to help get the supports and understanding and services. It's also, important because people then understand, oh, I get why he's, having a challenge in this social setting, or I get why she may need extra supports at work. And then, many times autism may describe the needs to others better than the X and Y difference, which I already talked about. What's XXY anyway? Okay, so I want to pass it on to Dr. Wilson now, who's going to talk about screening and evaluation for autism, and then we will go through and give some time for questions.
So we feel it's really important for all kids to be screened for autism, and it really should be, and I should say autism and social skill deficits, right? Because we want to make sure that they get the supports and interventions as early as possible, because we see that earlier intervention makes a difference. So most primary care providers are providing screenings before the age of 3. You certainly can ask your primary care provider to make sure that screenings are in place. But this is an important point, and this talk really is intended for people across the United States. So you will have regional differences in counties, differences in cities, differences in whether you live in a very rural setting or a more urban setting. So it is difficult to really describe the differences in screening and evaluation across the entire United States because it can be so different. And certainly when we get into international audiences, it's even more different. So, but at the end of the day, what we really recommend is an evidence-based neurodevelopmental assessment when there are concerns. So screening first, and screening is important, and then following up with evidence-based neurodevelopmental assessment. These usually include what's known as the ADOS, or Autism Diagnostic Observation Schedule, still considered the gold standard for testing for autism, a good developmental history. Sometimes is lacking. We want to make sure we get a really good developmental history so we understand the entire trajectory of the social skill developmental concerns. And then an adaptive behavior assessment. Adaptive behavior assessments are those assessments of what's the person doing at home, what's actually happening at home, not just in a clinical setting where the assessment's happening. And then there's usually additional developmental, cognitive, intellectual evaluation. And then for this discussion, what is important is consideration of the X and Y complexity. So it's not just autism, not just an assessment for autism isolated, but within the context of the X and Y difference. As Dr. Tartaglia talked about earlier, we know that there is a higher risk for language delays, language disorders, language differences. There's differences in cognitive skills, differences in learning. Anxiety and social anxiety needs to be part of the differential oftentimes. And then we know that there's attentional differences. So as a psychologist, this is a lot of the work that Dr. Middleton and I are doing. After the diagnosis, we oftentimes recommend starting in the school setting. Start with what is provided in school. Again, there's regional differences in this, where most individuals can get therapies in these various areas: speech, occupational, social skills groups. Social skills groups have been found very effective in the school-based setting where the friends are, and behavioral and psychology and social work support. And then you would want to add different interventions in the community setting, such as behavioral therapy and all the other supports that are available in your community. So what helps? These are the top 5. There's many things that help, but these are the things that in clinic we are oftentimes talking with parents about. Build on strengths. Start with the strengths rather than focusing on the deficits. That's for all of us, right? We all do better if you focus on our strengths and build from there. Adjust expectations. So try to match the social skill expectation to the social skills. So you provide a little support. This is something a lot of parents are doing. Here's the thing. Here's what we're going to do today. And then go from there. Reduce language demand. This is a very important point for our kids. and our adults is just reduce the language demand, then provide tools and be a good model. Explain what you're doing in a social setting. I was kind of frustrated with that moment too, but I took a deep breath and then I could go back and be a little better. And then this is another important point, and it is a point for many people. You don't have to have a lot of friends. A few good friends can be enough. So we would like to hear your questions. We would love to interact with you. So let's go to questions.